All right, good morning. This is Senate Health and Welfare, and it is April 17th, and it doesn't feel like it because we had snow again.
The UV rays are going to be high today.
What is it high gonna be?
UV.
Oh, it is?
I didn't get a pollen count this morning. I said one pollen.
What color?
And nothing blooming around.
Oh,
But it
anyway,
pops up.
well, we're just gonna keep thinking spring. So this morning, we're going to be looking at H482, the Green Mountain Care Board Authority Bill. And then we'll move on to the housing bill and our pharmacy 340B bill. And so we'll begin. And we have, we're going to introduce ourselves right off the bat. Steve, why don't you come on up? And Dr. Leffler, come on. And then we'll introduce ourselves once for folks who are either on the screen or here. And then we'll go ahead with testimony. So go ahead.
Senator Larry Hart, Orange County.
Senator Lawrence County.
Ginny Lyons, Chittenden Southeast.
Martina Rocky with Chittenden Central.
In Cummings, Washington District.
Hi.
So first of all, I'll just start out knowing that we are acutely aware of all the divisiveness that's happened in the media play on the issues related to the network and UVM and Blue Cross and Blue Shield survival. We understand all of that. Our goal is, and we understand really the huge step that I will say that the network took to resolve some of the issues with the Blue Cross and Blue Shield. And that was a courageous step to take, both on the part of the board and on the part of the hospital and the network, and we appreciate that. This bill was introduced, I believe, in the House to sort of put into statute some of the conditions around which all of the negotiation and the agreement came to. And what our goal here is to understand what, if any, guardrails are necessary to ensure that when we make decisions like this, that we're doing them in the best interest of Vermonters. So with all of that said, we have a bill before us and we welcome you and your testimony. So over there.
Thank you very much. So, Madam Chair, members of the committee, I appreciate greatly the opportunity to testify in front of you today. My name is Steve Leffler. I'm the president of University of Vermont Medical Center. I'm a lifelong Vermonter. I'm an emergency medicine physician. I practice emergency medicine in the medical center for more than 30 years, and I've been president for the past 6 years. I deeply care about Vermont, our communities, and the patients that we serve. We absolutely recognize that Vermont is facing an affordability crisis right now. I have son and daughter-in-law live here, young children, and they deal with difficulty with housing and all the other issues that everyone feels. And I'm here as Utah Health Network to try to be part of a solution. I firmly believe in the power of Vermont and our regulators and our commercial insurers and the healthcare system to work through this. I recognize that healthcare in our region right now is under intense pressure. Rising costs through the pandemic have made healthcare much harder to afford, but honestly also much harder to deliver. In November, the network made some mistakes. And coming out of that, I started really thinking about in November, how can we work together more collaboratively? And over 3 months and more than a dozen meetings, we worked hard with Green Mountain Care Board on a better path forward. That path forward is the agreement that Senator Lyons just talked about. The first part of that agreement was $11 million in funding for non-UVM Health Network primary care providers across the state. We're acutely aware that they lose funding from the blueprint from OneCare in 26. And we need as stable as possible primary care workforce in the state. And so this is a strong investment to help get them a bridge to the next healthcare reform, hopefully ahead, kicks in 27. Secondly, we are also acutely aware of Blue Cross's challenges right now. We had an ongoing dispute with them over 22 and 23 settlements. And this agreement resolved those issues with a $12 million payment to Blue Cross. We made a commitment going forward to submit compliant budgets to the Green Mountain Care Board and follow their guidance. This year, that guidance is, we're building a budget right now. A bunch of my team was working on that this morning. Means that our revenue growth can't go over 3.4%. Our commercial rate can't be more than 3%, but for the medical center, it'll actually be less because of part of this agreement. We have $20 more million in enforcement to work through in the 26 budget. And honestly, the most challenging component for 26 is the expense growth can only be 3%. We have many things in our budget that are growing more than 3% per year. And how to bring those cost expense in line to meet guidance is one of the most difficult things I've done as president of the medical center. The agreement, I think also very importantly, has a 5-member work group, which includes two representatives from the Green Mountain Care Board, 2 trustees, 1 from the network board, 1 from the medical center board, and an independent liaison. There was a lot of work in that term. The term we use, we can talk about that later. It was announced, I believe, yesterday. It's going to be Mike Smith. We've already contacted him and we have meetings being set up for next week. This group will work on how to make the network more efficient. We put some dollars aside to potentially use some outside consultants. My thinking on that is that we spent the last 10 years building a network, building shared services, growing, and now it's time to optimize it. And we can talk about all these. We haven't done that better. I do think about things like pandemic, all kinds of other issues, but it's critically important now that we squeeze the value out of the network. And I firmly believe that work group with consultant help, outside perspective, we're still a relatively small, young system, can't help with that. Finally, we agreed to align any performance-based compensation for leaders with state goals. So the Green Mountain Care Board will have a voice if we have performance-based compensation going forward, and that's an if. We would align with those performance metrics would be with the Green Mountain Care Board and what's good for the state of Vermont. These efforts really are a first step in rebuilding trust and how working together to improve affordability for healthcare in the state of Vermont. This plan reflects our strong commitment to reform and sustainability, but it's going to be challenging. There's a whole bunch of challenges in front of us how to do this. But once again, I'm very grateful to the partnership with the Green Mountain Care Board for you having the opportunity to testify today to work together on this, because I do believe in Vermont and I do believe we can make it better. I want to just talk about a couple parts of the bill. And so I already mentioned this, but it's very clear in November we made a mistake, or more than we made mistakes. And this bill was reaction to some of that stuff that happened in November. And we have the medical center, the network have already agreed to have an independent liaison. We've already agreed to 16 months of work together. And we've already agreed to many of the provisions in this bill. I would like to say on behalf of the other hospitals in Vermont, they don't deserve to be facing this potential scrutiny or actions from the network. And so I would ask you to consider either delaying implementation till after you've had the 16-month run, understand how well it works and how we can learn from it and do better. Or I wonder if it's needed as we've already agreed to the provisions. The second one I want to speak to just briefly is the provision to allow Green Mountain Care Board to adjust the hospital's commercial insurance reimbursement. We already are highly regulated and we get our budget guidance, which kicks in October, and then we live with that guidance for a whole year, no matter what happens. If costs go up, if we get a new contract, if pharmaceuticals change, the federal government takes away Medicaid money, which we're super concerned about right now. We have to live within that budget, for better or worse. Days cash on hand is really our balance sheet. It's our savings. And days cash on hand is how the medical center and the network weather uncertainty and challenges. At the end of 24, fiscal 24, the UV Health Network had 143 days cash on hand. In the medical center, at the end of 24, had 134. A lot of that has to do with the stock market. Okay, we have investments, and the stock market did very well last year. You can imagine it's much worse now. At the end of February, the medical center only had 118 days cash on hand. A strong academic medical center has between 170 and 200. And the network only had 128. That matters because other changes that could happen to us, your balance sheet is how you are able to deal with that. It costs $6 million a day to run the medical center. Every day. Every weekday, every holiday, $6 million a day. And we are working hard on every single thing we do to try to drive that expense down. But that is our cost. More than 60% of it is labor. It's the people who take care of us when we're sick. It's our nurses, our support staff, our techs, our x-ray technicians, our laboratory people, our physicians, and the people who do the back end function as well. A sudden change in days cash on hand, first off, it happens naturally. Just told you from February to now, I'm sure it's gone down. I couldn't get you the exact for today, but I'm sure it's gone down. Has an impact on how strong we appear to the bond market when we're trying to borrow money. When we borrow money, we have bond covenants. Many of them might have a issue in there that we have to be between, let's say, more than 135 days cash on hand, or 125, depending on the bond that we take. If it drops because of the stock market, if it drops because our expenses are too high, or if it drops because this action happens and some of our money is taken out, we could violate a bond covenant. The bond market has the right to also give us an independent observer. And between the bill where the Green Mountain Network potentially assigns a second one, when we've agreed to, and a third one from the bond market, we could have 3. That will be very difficult. I know you heard from Rutland, I think it was yesterday, but the challenges.
Last week, we did, yeah.
Yeah, last week. With the challenges of having your days cash on hand eroding, possibly violating bond covenants. That is a real issue that we should be careful about as we think about how to do this and shore up Blue Cross, which I understand is critically important. If this bill does pass, right now we have strong guardrails in place for the budget process. How the Green Mountain Care Board builds our budgets, gives guidance, how we submit them. And we would hope that if the bill does pass, those guardrails will be added to this to make sure that we are not jeopardizing quality, safety, solvency of a hospital, access to put this bill in place. It does feel in some ways that you might be shoring up one part of the health system and weakening another one, but that's a potential outcome. And then just finally, I'm just going to mention that we believe the triggers for the bill should apply consistently across all hospitals. So the way it's written right now, if you're part of a network, it could be enforced either if you had a positive margin last year, or if your days cash on hand is over 135, either one could do it. So you could be in a situation where you eat by with a positive margin last year, the network's days cash on hand is okay. This year you could be losing a bunch of money. It could still be enforced. That could really be an issue. Or the opposite is true. You could have consumed some of your days cash on hand, that could be low, but your margin was a little better. So we do think that should be consistent. And I just want you to know, and I already mentioned this, that days cash on hand fluctuates day to day, month to month. Big drops in the market, consume days cash on hand. I'll stop there. I'm happy to take questions. Thank you.
Thank you. First question is, can we get your testimony to Kiki so that we can post it?
Yes.
Yeah, that'd be really terrific. So we're hearing some suggestions that are in there. Can you talk a little bit about the relationship that you do have with Blue Cross and Blue Shield, and how what's happened in the contract will maybe improve access for patients?
So we are extremely focused on patient access right now. So we have done a tremendous amount of work this fall to open up 2,000 more primary care slots within the UVM Health Network in our primary care spots by optimizing our schedules. That's using a tool we made a big investment in. Epic now helps make sure every schedule is full. So that's improving access. And equally important, we're using something called Care Direct where you can get an e-consult if you see your primary care doctor and you have a question that in the past you had to see a diabetes doctor for. It's a relatively easy thing. You can do a consult through the electronic medical record and within 36 hours get an answer back. We've been doing it. We've done more than 2,000 of them this year. That's 2,000 appointments that can be given to other people who need them. More than 90% of the time, it answered the question, solved the issue. It's much cheaper for patients. They don't pay for that. It keeps them out of the specialist office and keeps access open for other people. In terms of working with Blue Cross, we worked hard on coming up with this settlement. We've been having regular conversations with them. We're very aware of their situation. We are working right now on other ways to partner better to make care more affordable for Vermonters. And we fully understand the situation with Blue Cross.
There's a lot in what you have said, and I know that we've had conversations specifically about the relationship between affiliated primary care versus independent primary care, and then the reimbursement rates for each of those being, higher for the affiliated and lower for independent. And I guess our concern here has been, how do we ensure that those primary care docs in the Northeast Kingdom and other parts of the state have sufficient resources to survive? And I don't know I know you've been thinking about that. I'm sure you have, but maybe you could reflect on that and give us your thoughts on that, just in principle, and then we'll go to Senator.
So interestingly, I was involved in the design of One Care. At one point, I was the chair of the One Care board, and One Care put many things in place to stabilize primary care in Vermont. We could argue maybe not enough, but there was very significant dollars. There was very significant dollars through One Care to shore up primary care. Multiple primary care practices have testified, I'm sure, the value and power of One Care. There's a lot of other issues with One Care, which we don't have time to go into today. This payment for 26 is acknowledgement of how important that primary care is to the state of Vermont and hospitals, by the way. If someone is super sick in Newport tonight and can't get what they need and end up in one of our hospital beds, which was already really full, that served no one. So I do think that advanced payment models, like the AHEAD model, there's other primary care models that we can look at. There's other ways to partner to make them stronger. Being an independent primary care right now is extremely difficult. It's unbelievably challenging. They face the same pressures as running a hospital and a small practice without the scale to do all this stuff. And so I sympathize with that. A bunch of them are my friends. It's really hard. And so I do think we have to be creative about how we shore up what they have. They have the same challenges, literally, as the medical center, just on a smaller scale. HR is a big expense for them, paying their employees. Healthcare costs are a real problem. They'd like to get on electronic medical record like Epic. How would they do that? I think there are some things there, specifically like around Epic. There might be opportunities on them, which I do think if we had statewide, would decrease the cost of care.
But, and we did put that into our bill, so we're on the same track. So it's great. So Senator, go ahead.
Thank you, Madam Chair. Thank you so much for being here today. I know these are hard times, and I appreciate your courage in diving into this work. I know it's not easy. I really appreciate the settlement agreement. I am excited about the new position of, what do we call it, independent liaison?
Yes. That was a number of meetings.
Yeah, I there's so much good stuff here. I did want to follow up on something that you said. I'm curious about it. You mentioned that in terms of this bill, that you are concerned about the other hospitals facing scrutiny because of the network. And I guess my question is kind of a broad one, but what is wrong with scrutiny? And if you are acting in a forthright manner, what's wrong with being scrutinized? It seems like that can actually be a healthy thing.
So I don't disagree that scrutiny is a good thing. And I think hospitals try really hard to be transparent. Hospitals are already in Vermont heavily regulated. We have a board. We have independent boards in every hospital in the state. We have management. We have the Green Mountain Care Board, we have the legislature. It adds one more piece. My belief on this is I think we're going to learn a lot over the next 16 months. I think we're going to really understand much better what worked really well. And I believe parts of it are going to work really well. And I wouldn't be surprised if some parts are a little clunkier than we anticipated. And so, since we've already agreed, I think there's an opportunity here to learn from us. It makes the boards nervous. Is this person interfering with what the community boards do and having say over their governance responsibilities? That was a big part of the discussions on when we were working through this. Our boards, both the network board and the medical center board, how does this impact their fiduciary responsibilities and their decision making? And it adds, in some ways, more oversight over management, which I understand why you want that right now, but it does add an extra layer of complexity.
Okay, thank you. I would just offer that the next 16 months are really critical and also very at this point kind of terrifying and uncertain. So the more hands on deck we have, the better in my mind. My other question, I live in Burlington, so I'm a little familiar with bonds and bond ratings and bond covenants and all those great things. So in terms of your bond covenants, I'm just wondering, I understand you want to adhere to them for sure. What happens with your bond covenants though, if we lose an insurer and if we continue toward the brink of, something really disastrous?
I want to be clear, I believe it'd be catastrophic if we lose Blue Cross, and we should do everything in our power as a state, as a healthcare system, to figure out how to keep them going. Without question, if Blue Cross goes under, it will have a big material impact on what we do. So if we lose 300 million of Medicaid dollars, so will a bunch of other stuff. So I'm not saying that I don't think we should work to shore up Blue Cross. I just want to make sure that we don't fix one part and then have another part, and then next year trying to fix whatever that looks like. So our balance sheet before the pandemic, I believe we had more than 200 days cash on hand. It really helped us weather the pandemic and step up and do many, many things. I really hope we're not having a pandemic again. But I do think there could be multiple other huge financial pressures on hospitals across the state of Vermont coming up this summer, fall, or the next couple of years. Having stability and strength in your balance sheet allows you to weather that. That's what the bond market looks at. But I appreciate your question.
Other questions, committee? We're good? Thank you. And thank you for being here. Well, we really appreciate your time. And please do get your testimony to Kiki so we have it. There's a lot of data in there that's critically important for our decisions.
Thank you.
Oh, Mike.
Good morning,
Good morning.
Mike Fisher, healthcare advocate. What order you were going this morning? So
Here we are.
here we are. Happy to be here. I guess it shouldn't surprise the committee to hear that the healthcare advocate office has a bit of a different perspective than UVM MC or UVM HN. I'll start with a recognition of the work that's just been done. I also appreciate the work of coming to an agreement. I think it's a good thing. I think a world of attempted enforcements and litigation only lands us in months and months and months of high legal bills. I don't know how they turn out at the end of the day, while our system takes further and further steps towards this. And so getting off of that track was a good thing. I felt critical of some of the details in that agreement, as I've said publicly, but I feel good about having achieved it. And I also want to recognize that what I just heard UVM say is noteworthy, recognizing that they made some mistakes and that they need to be reset. And so I think I'm going to take them both. Take them give them credit for that and take them at their word, and also believe that we need to keep as much checks on this system as we possibly can. We don't have time. And we don't have time to run the next 18 months, whatever, out and see what we learn, and then decide what we have to do afterward. And so I come with just a bit more urgency. I guess since I just said, like how devastating it would be to lose Blue Cross in the QHP market. Let me just play that out for a second further. I don't believe the other carrier stays in the market if one of them is. I think it's clear that we would have no insurer in the QHP market. And just pause on that for a second. No insurer, the small businesses to individuals purchase self-insurance. It's more than devastating for a hospital or for that. It's catastrophic for our entire finance system. And it's not beyond the range of possibilities. So that's that sort of disaster, but there's another disaster playing out right in front of us, and that's assuming that we can figure out a way to raise the rates enough. Blue Cross and MVP will be delivering their proposed rates, and I think on 12th of next month. And so that's not far away, and because we're not changed anything about the way we're actually running this system. Expect similar rates this year, I think, as we've seen in previous years, and gun to our heads. In effect, I'm sorry for that image of we the public interest. We after advocate for Green Mountain Care Board and hospitals and everybody have to provide the rate increases to the carriers so that they can continue to pay claims, stay in the market and pay claims. And that is such a, I don't need to tell you guys, but we just need to say it. It is a tremendous economic strain on every part of Vermont. And I don't know how small businesses sustain another 1% rate increase. I don't think they do. And it plays out very much the same way for taxpayers, for public employees, and it plays out in every other. We tend to talk a lot about the QHP market, but the Medicare supplemental market's in tremendous trouble, and we hear seeing stress in the large group and some funded markets as well. So that's my high level. I appreciate that we've come together, that the board and the hospital have come together with this agreement. I think it's a good thing, and it doesn't change my advocacy for the urgency and the need for this bill, for an emergency powers bill, given the tremendous instability and tremendous risk that we have. I have one detailed suggestion about the bill. From day one, we looked at it and thought days cash on hand was a poor measure. It was something that was fairly manipulatable by a hospital, and so we wanted to at least express a suggestion that the measure of solvency was something more like net worth or unrestricted assets, something that hospitals have to report on their auditing financials, and harder to, of course the market changes and things outside of our control, but if we're trying to measure how stable an entity is, unrestricted assets feels to us like a better way to do that, and we have to do a little bit of work to figure out what the trigger was if we wanted to go that way, but happy to answer any question.
My first question is the same one. Can we get your testimony to keep you so we have your recommendation?
I'll have to write it down.
Okay, yeah, but no, do that, please.
Yes.
Because, we're not coming back to this bill tomorrow. We'll come back to it next week sometime, probably. So, I can't tell you what day, but somewhere on our agenda coming up.
Yeah. And maybe I could just add, I have dubbed this bill the emergency powers bill, not H4 or whatever it is, ever since its inception. And just with that in mind, given sort of the extremeness of the situation we're in, It wouldn't surprise, we're gonna need to have some flexibility in our regulators going forward, so.
So, and our concern here is when we put emergency authority into statute, that we do it in a balanced way so that we're not throwing the baby out with the bathwater. I mean, that's really critical, and I think we all understand that. And we also know that we have 126 going forward that may help balance off some of the issues that we're concerned about. And we're in really dark times. The dark cloud of authoritarianism is hanging right over our heads. And it will continue to do that. We're going to need to be thoughtful, all of us working together. Appreciate your thoughts on this. Thank you.
Thank you.
And my dark cloud authoritarianism is going to continue almost every day until it disappears, until the sun comes out. There it is. So, Owen, thanks for being here. And Mike, please do get that.
Mary Caroline.
Good morning.
Thank you for having me. My name is Owen Foster. I'm the chair of the Green Mountain Care Board. And I support H482 as written. I'm open to some tweaks and modifications. I can explain those. But the bill, I think, is critical to pass at this time. I want to address a couple important points. I agree with a lot of what Dr. Leffler said. He and I have been working very, very closely for many, many months through many hard issues, and we have come together to find a path which is beneficial for the state, and I appreciate it. There was some discussion about the overseer portion of this bill, and the hospitals object to having an overseer in certain situations. I want to point out the trigger for whether or not the board can appoint an overseer is not whether or not the hospital network, the UVM network, did bad. We can't appoint a liaison under this bill because the hospital network did bad. So it's not that they don't deserve it, it's that they can avoid having it. I don't want to appoint a liaison. I don't want to appoint a monitor. I don't want it. What this does is protects against situations where one is necessary. There are two triggers in this bill for an overseer. The first trigger is whether or not, I forget the trigger, but one of the triggers is whether or not there's been misrepresentations made to a state authority while arguing for higher commercial rates and budgets. Keep in mind, when we're deciding budgets, is your constituents' money. Sometimes we talk about insurers as if they're some sort of pariah, and I've been involved in lawsuits with insurers, and I'm not defending all insurers across America. However, Blue Cross Blue Shield of Vermont is our only Vermont domiciled insurer, and it has 6% administrative costs. To me, that means they are 94% just us. The money they spend is our money, is your constituents' money, is your small business's money. Go walk on your Main Street. They are paying that money. That's an important point to remember. So the first step is, do we want a situation where there may be misrepresentations when we have to make these very hard decisions about how much more money your constituents have to pay? No, we don't. We cannot tolerate it. We cannot have. We published court orders in recent years. We have made findings, public findings and written orders of a lack of credibility of representations made to the care board. Okay, that is something 5 independent board members and our council signed on to us saying publicly that we believe there's been a lack of credibility in some representations in budget submissions. Sometimes their inaccuracies are not at fault, they're not intentional, it's just hard to do, whatever it is. Regardless of why, they lead to higher healthcare costs that we can't avoid. So any hospital can avoid having the 482 authority or a monitor by not making misrepresentations. And to actually accuse somebody or make a finding, it's not an accusation, to make a finding of misrepresentation is a serious, serious thing to do. We have not actually found that we would hit that step. We've never really looked. We found credibility issues. We found inaccuracy. So anyone can avoid it by just not making a misrepresentation that causes the board to actually make that kind of serious finding. The second trigger to overseer, I think is the language, is whether or not the hospital is out of compliance with its budget. In the last 2 years, fiscal year 23 and 24, we've seen over $150 million above our budget orders. The taxpayers and our small businesses and people pay. That creates an incredibly chaotic and unpredictable healthcare market. When you add $150 million to some of the highest costs in the country, your constituents suffer. It stagnates economic growth. It hurts our demographic interests. It hurts our school budgets. It hurts our taxes. So this bill protects against that situation where there's budget violations, because if there are, you might have somebody who comes in to help ensure you do not. That's all it is. We want compliance with budget orders, and this will prevent that difficult situation from arising again. So those are the two triggers. I think that's important. Hopefully we'll never have a budget violation again. Hopefully we'll never have a situation where we make findings of a lack of credibility. So I view this as something that's not very likely to happen, because we've made clear that that's not acceptable. Number two, the other provision is adjusting hospital prices. And I agree with Dr. Leffler. We want very strong hospitals. We want every hospital strong. It's not a reality we can have right now. And every single point that Dr. Leffler correctly made as to the importance of Blue Cross's solid balance sheet applies to Blue Cross Blue Shield. They have bond ratings. You know what their bond rating is? C+. You know what happens when they have a bad bond rating? They pay 8% to borrow $30 million to survive, to pay claims. So we have to be concerned about a hospital's bond rating, and we have to be concerned about the insurer's bond rating. Both of them cost us more money. They have to be tethered together. They are all of us. The hospitals are us and the insurer. And we can't lean too hard on the insurer and have this inequity, because it costs us a fortune. My understanding is Blue Cross has $28 million to bank. They pay $35 million a week in claims. You know what that day's cash on hand is? It's less than 145. Wait less. The network has both, at the end of fiscal year 24, the last financial I saw, had over $1.3 billion. Other hospitals have hundreds of millions of dollars. I'm not saying that that's inappropriate. I want them to have that money, but we can't have that and then have the person paying the claims have single-digit days cash on hand. When they have single-digit days cash on hand, what happens? They come to the board and they need a 20% rate increase out of your favors. I predict that this year we will see rate increases, requests of 15, potentially up to 30%. Tell me if you have a constituent that can pay that. Why is this so critical? If Blue Cross cannot pay the claims, the system fails. That means UVM will fail. I believe UVM will fail. Maybe they'll hang on longer. But these small practices that rely on Blue Cross as well, your FQHCs, your independent primary care doctors, are so critical. Your DAs or mental health providers, they have single-digit days cash on hand. If they don't get paid, they close their doors. Or we have to charge constituents 20, 15, maybe even 30% more. Last year was 20% on the highest commercial insurance costs in the nation. So this provision is critical to have that equilibrium, to tether everyone together. I totally agree that hospitals' financial health is critical, but it is actually only harmed if the insurers is poor. This bill ties them together in an extreme situation. 135 days cash on hand is adequate. 145 is more than adequate. The provisions in this bill would only apply currently, if this were a law now, it would only apply to 3 hospitals. It would apply to the network, the medical center, Rutland, and I believe it's Mount Scottney, which is part of Dartmouth. Okay, so you have a Dartmouth network with $1 billion+, the medical center or the health network here with $1 billion, and Rutland. That's it. And the only other point I would make is that if hospitals have 7 days cash on hand or 5 days cash on hand, what happens is they come to the board and they say, we need a lot more money out of commercial insurance now. It happens. We did it last year. Probably had a rough 60 days cash on hand, something like that, 50, 40, somewhere in there. What happened? They came in and said, we need 7% more out of Blue Cross. UVM has come in for a mid-year, said, we need more money. Raise our rates, I forget the number, 5%, 10%, whatever it was. Why can't we lower the price when the insurer is going out of business? And they're in worse shape than any of those hospitals that have received rate increases. The only other point I would make, did Professor Whaley testify here, or was he in House Health? House Health. So we're talking about reference-based pricing in Senate Bill 126, which has the reference-based pricing in it. Some of our Vermont hospitals, the larger ones, the two of them would be subject to this bill, have some of the highest commercial prices in the nation. Not the highest, but they're up there. They're way up there. So what we're actually talking about is reducing some of that. This is reference-based pricing. You're lowering the price in this scenario under 482, which is something we have to do as a state, and you all passed a bill to do it. That's what this is. It lowers the price in an extreme situation. I support it if we have to do it.
Thank you. And we have your suggestions for the bill, but it would be great to have your context also in testimony if we can get that. And
See if we can get transcribed.
yeah, good. And I do probably should have said this in the beginning, and I think we've said it before, but thank you for the work that you're doing on this. This is huge, and the negotiation that you've gone through with the medical center and the network it really has been very reassuring to the public about the seriousness of improving healthcare for Vermonters, and the costs are, as both you and Dr. Leffler said, overwhelming. And Mike's also said this. It is overwhelming for citizens. We don't want people to become uninsured. We work so hard to bring them into the fold.
If you have 70, if Blue Cross is not able to pay claims, MVP is gone.
Yeah.
They need $60+ million to take on Blue Cross's portfolio of clients. They will not stay. They cannot afford to stay. If we have 70,000 Vermonters that cannot even get insurance, they cannot even get it. That is not a scenario we can have.
So I do have a question for you, and it's probably one that we're going to be pondering on into next session. And we've had this conversation before in this room and with others, and that is, as you look at Blue Cross and Blue Shield and other insurers and rates, insurance rates and budgets, obviously the Green Mountain Care Board has one role, regulatory authority in that realm, but DFR, Department of Financial Regulation, also plays a significant role in that. And then we know that AHS also has its own regulatory role to play. So on that, up there on that higher level, those things seem to be separate and maybe not even equal, but very separate. And how to look at and to dig into what's happening within each of those regulatory bodies and how do they fit together. You know, we're in a strange time now with the potential of losing Medicaid, and so AHS is dealing with that, and we're all fearful of it within for our constituents and what's going to happen there. And then we hear Blue Cross and Blue Shield, our small businesses, our ESI, all of that is going to fall apart, and then we can't lose our hospitals. They're important service organizations for us. So the regulatory dome is split. So we will, you know.
It is and it isn't, if I may.
Yeah.
I speak with DFR almost daily. I speak with AHS almost daily. We have an hour-long meeting every single week, if not 2 hours, to meet and work on these issues. It's split, but we also work together really closely all the time.
I understand that, but there are places within each of those where improvement can help. And so that's what I'm thinking about. I'm not thinking about the lack of collaborative opportunities and work. It's there. But we don't want to have black boxes where we can have shine light. Well, this will be a different discussion another time, but it is important, I think, to all of us. Questions committee that you might have of Chair Foster. Thank you. I mean, I really can't say thank you enough. This is a huge issue, and you all have been working on this, and we really respect and thank you for that work.
I appreciate your work.
Ended there. You know, we always get blamed for everything, so we're willing to take blame again, right? But there's no blame here. There's a lot of work that has to be done. We can't let Blue Cross and Blue Shield go under. We can't let our smaller healthcare services go under, particularly our primary care folks. And we can't let our hospitals sink when Blue Cross, if anything happens. That's, we got.
You can't keep increasing insurance rates. Just
No, we can't keep increasing insurance, right? We can't pay for it. No, I greatly appreciate this. So we're gonna take a short break until 10 o'clock, and then we'll come back onto H91, which